Okay, well, good afternoon, everyone. Welcome to another seminar series for both the UBC School of Kinesiology and the UBCO School of Health and Exercise Science. Today, we have the pleasure of having Dr. Jordan Guenette with us. Dr. Guenette was like a special invitee from the graduate students. So we're really looking forward to his talk. He's going to talk about some of his background, which involves like being in the School of Kinesiology at UBC, and then his postdoc at Queen's University, and then talk about the research he's currently doing at UBC. So for the questions, please use the private chat message to me, and then when we get to the final period question, then we can go through a one-by-one that way. So Jordan, looking forward to your talk. Thanks for accepting the invitation.
Well, thank you very much for having me. I do have some financial disclosures that I am required to make before we get started. So I will be talking about a clinical trial today that's funded by Boehringer Ingelheim, which is a pharmaceutical company. I also serve in a number of different roles for a company in Vancouver called Agarty Technology, but none of today's content will be directly related to my conflict with Agarty. Okay, so when Jean-Sébastien invited me, he asked me to spend a little bit of time talking about my academic journey. So I'll walk you through my various stages of training and into my current faculty position. I'm then going to spend a little bit of time talking about how, as an exercise physiologist, I approach rehabilitation research. And the example I'm going to use from my research is the work we're doing in interstitial lung disease. So I'll tell you a little bit about the pathophysiology of ILD. I'll then spend a little bit of time talking about the acute physiological and sensory responses to exercise in these people. And then finally, I'm going to spend some time on an intervention that we've been very interested in over the years, and that's looking at hyperoxia or supplemental oxygen to improve symptoms of dyspnea or breathlessness and also improve exercise tolerance. So first of all, I do want to apologize to anyone that was at my CSEP presentation a couple of years ago, where I was also talking about my academic journey, but hopefully this will be new for some of you. So I basically graduated high school in Edmonton. I had no idea what I wanted to do with my career. I did pretty well at math and physics in high school, and so I decided, you know, why don't I give engineering a shot? And that's about as much thought as I put into this important decision. And so I went to U of A, studied engineering, and then I would say within 2 months into the program, I realized this was a big mistake, and this is not what I want to spend the rest of my career doing. And I made the very difficult decision to drop out of university. And as one of these overachieving high school kids, dropping out of university was the ultimate failure. I was really embarrassed that I did this. And so after I quit, I took a full-time job folding t-shirts at a discount men's clothing store in West Edmonton Mall. This is the store. And when I wasn't working, I was training for middle distance running. And I was at track practice one day, and a teammate came up to me. He saw me reading about running physiology, something that I was very interested in. And he said, "Jordan, why don't you just study kinesiology? You're always reading about exercise." And I was like, "Oh yeah, that's a good idea." But in my head, I was like, I have no idea what this guy is talking about. I've never heard of the word kinesiology before. And so that night when I was done track practice, I went home, I looked it up on the internet, and I could not believe what I was reading. It was exactly what I wanted to be doing. So I applied to the School of Human Kinetics at UBC, now of course known as the School of Kinesiology. But briefly, what I learned from this experience, and I know it's a cliche, but don't waste your time doing something that you aren't passionate about. I was very lucky that I made that decision as early as I did. And that quitting doesn't always make you a failure. I certainly didn't realize it then, but I do now. And I can say that this decision was probably the most important decision of my life, because everything that I have today, both personally and professionally, was because of that pivotal moment in my life where I decided this isn't right for me, I'm not going to continue. So I went to UBC. I loved what I was learning. I admittedly was not focused on getting good grades, and I was more interested in athletics. And when I got to my second year, I started to think, you know, I probably need to start thinking about what I'm going to actually do with this degree. And one of my teammates encouraged me to reach out to this guy here, Bill Shield. Said, "Jordan, look into this guy. He's doing really cool physiology research." And sure enough, Bill was teaching me statistics in the kinesiology program. And so after class, I went up to Bill. I asked him if he'd be willing to take me on to do some work in his lab for the summer. And Bill was a little reluctant at first because he wasn't very impressed with my undergraduate transcripts up to that point, but he took a shot with me, and I was really appreciative of that. And so when I was working in his lab, within, I would say, 2 weeks, this is one of these summer NSERC positions that I got. And within 2 weeks, I realized this is exactly what I want to be doing for the rest of my career. I want to be this guy, Bill. I want to run a physiology lab. I want to teach. I want to mentor. And so that was the start of my academic journey. And I was very lucky that I figured it out as early as I did, because it allowed me in my undergrad to now plan out the next 10 years of my academic training so that I would be in the best possible position to land a tenure track faculty position. And if you're interested, I can talk about some of the strategies that I used in the Q&A session. Okay, so right after finishing my undergrad, I did my MSc with Bill, and then I went right into my PhD also with Bill. Some people are critical of trainees doing all of their training in the same lab. I don't totally agree with that perspective, but Bill and I both definitely recognize that there's value in getting exposure to other research environments, other mentors. And so Bill helped facilitate an amazing opportunity for me to go work at the University of Copenhagen and at the University of Athens with Rob Bushell, who's now the School of Kinesiology's director in Vancouver. And we published a number of papers from these collaborations. Bill was not an author on any of them. You know, very few supervisors actively encourage their students to take off for months at a time and do research with other people. And that's because Bill was primarily focused on what was in my best interest and what was going to position me well to succeed in my career. And so when I finished my PhD, I decided I want to branch out even further and move into the clinical world. So I did a postdoc fellowship at Queen's with Dennis O'Donnell. He's a leader in the area of respiratory medicine. He's a respirologist, and he's a clinical exercise physiologist that focuses on COPD. And this was a really important turning point in my career because it opened up many opportunities for faculty positions. Not only was I now competitive for kinesiology kind of programs, but I could compete for positions in respiratory medicine, physical therapy, and other medical programs. And so that's where I ended up, in physical therapy in the Faculty of Medicine at UBC. I feel very fortunate to be in the Department of Physical Therapy. We have wonderful faculty, and I really appreciate the fact that they took a chance on me, because I'm the only faculty member in the history of the department that's been hired that does not have a physical therapy degree. And I think it speaks to the fact that there's this recognition that exercise physiologists actually can play a very important role in informing rehabilitation medicine. And so that's, I hope to make that case today in my presentation. All right, this is my lab. It's called the Cardiopulmonary Exercise Physiology Lab. We're located at the Center for Heart-Lung Innovation, formerly known as the James Hogg Research Center. Our center's been around for over 4 decades. And my lab specifically looks at the mechanisms of dyspnea or breathlessness and exercise tolerance in both healthy people, but also in those with chronic respiratory conditions. And ultimately, the goal of this research is to develop more effective rehabilitation interventions to improve symptoms of breathlessness, improve exercise performance and quality of life for those with a number of different conditions. And the main populations we work with in the lab, and the one I'm going to focus on today is the work we're doing in interstitial lung disease, but we also do a number of studies in cystic fibrosis, COPD, and in a variety of healthy individuals. All right, I want to spend just one slide walking you through my approach to rehab research, again, from the lens of a physiologist. So the very first step when I'm starting my research program is to identify a clinical problem that is very important to patients, and ideally a clinical problem that's interesting to me as a physiologist. And so the 2 things that I wanted to study included dyspnea or breathlessness and exercise intolerance. The next step is to carry out mechanistic physiology experiments so we can identify the mechanisms associated with those clinical problems that we identified in step 1. For step 3, we want to identify potential therapeutic interventions that should theoretically address some of those clinical problems. And in my lab, we study both pharmacological and non-pharmacological interventions. For step 4, we want to see what happens during an acute bout of exercise with that intervention. Can we acutely improve exercise performance? Can we improve symptoms of breathlessness? And if we can, then the final step is to do a larger randomized control trial where we use that intervention in addition to exercise training. So a several-week exercise rehabilitation program with the idea of using that intervention to augment the beneficial effects of their exercise training. So I'm going to go through all of these steps today with one component of my research program. Interstitial lung disease, this is not a single disease. It actually is an umbrella term for several hundred different chronic respiratory conditions that share common pathophysiological features, primarily inflammation and fibrosis of the lung tissue or scar tissue. And you can see here is an image to the right. I don't know if you can see my mouse, but you've got on the top right, you have all these alveoli, these air sacs, and you've got pulmonary capillaries surrounding them. This is a healthy lung. In people that have fibrosis, they get all this scar tissue formation, which makes the lungs incredibly stiff, so they can't expand their lungs very well. And this is why it's called a restrictive lung disease. And gas exchange is also significantly impaired, and I'll walk you through the mechanisms of that a little later. The most common interstitial lung disease is known as idiopathic pulmonary fibrosis. The median survival is around 3 years from when they reach a diagnosis. It's a very devastating disease. There are a number of risk factors for developing an interstitial lung disease. This is not a complete list, but some of the key risk factors include things like age, exposures to occupational and environmental toxins. This could be things like asbestos exposure, exposure to silica. If you have a smoking history, if you've been treated with radiation and chemotherapy, and also there's a genetic component. And dyspnea, or shortness of breath, is the most common symptom, and it's strongly associated with reduced quality of life and mortality in this population. So why is dyspnea important? Why do we care about studying this? Well, people with respiratory conditions, they develop dyspnea during moderate levels of exertion. And for many of these people, dyspnea can be incredibly debilitating. It's very distressing. It can provoke fear, panic, and anxiety. So naturally, people that experience these uncomfortable sensations will avoid the things that cause it. And in this case, they avoid exercise because exercise is a key trigger for dyspnea. And as everyone on this call knows, when you avoid exercise, you become physically deconditioned. And when you become deconditioned, your muscles are weaker, you now develop dyspnea on less strenuous activities. So you start to avoid those activities. And then you become more deconditioned, and this essentially spirals out of control to the point where many of these people, they have a really hard time engaging in very basic activities of daily living without incapacitating levels of dyspnea. They will be very short of breath during things like brushing their teeth or making their bed. And obviously that has a profound impact on their quality of life. So in my lab, we want to try to intervene very early in this process so that we can keep our patients physically active and able to participate in structured exercise. All right, dyspnea, it's a very complex symptom. It's defined as this subjective experience of breathing discomfort that's made up of multiple qualitatively distinct sensations that vary in intensity. And what we typically do to address this, we have patients do an exercise test, and at the end of the test, we give them 15 different descriptors of breathlessness. And we ask them to select all of the phrases that best apply to how their breathing felt at its worst near the end of the exercise test. And then we can cluster them into these various categories as shown on the y-axis to the left here. And so when we do this in a healthy, normal population, what you and I, presumably most of us are pretty healthy on this call, when we're doing a maximal exercise effort, we'll probably describe our breathing as this sense of increased work or effort. Our breathing is requiring more work, more effort, and our breathing is feeling very heavy. These are not necessarily unpleasant or distressing symptoms. This is the normal expected response to exercise. In contrast, people with interstitial lung disease, of course, they also will say that their breathing requires more work and effort and that their breathing is heavy. But they select phrases of dyspnea that are very distressing. They select phrases related to unsatisfied inspiration or air hunger, this inability to get air into their lungs, or this inspiratory difficulty. They also describe their breathing as very rapid. And so these more unpleasant qualitative descriptors of breathlessness we feel are probably the things that are driving these patients to make those behavioral modifications to their activities. Now, when we stress our patients with a cardiopulmonary exercise test, so this is an incremental cycling test that starts at a very easy intensity and it just progressively gets harder and harder until they have to stop. And we simply measure the intensity of their dyspnea every stage of exercise using the 0 to 10 Borg scale. And you can see that compared to their normal age and sex match controls in black, people with interstitial lung disease in red have much higher dyspnea ratings for any standardized oxygen consumption or work rate or ventilation. So for us, we've now identified the clinical problem. It's dyspnea, it's important. So now we have to understand the mechanisms of dyspnea. And one of the ways we've been studying dyspnea is to look at the neurophysiology of dyspnea. And so we use a technique that allows us to measure diaphragmatic EMG. This is a catheter that we use. There's only 3 of these being used during exercise in Canada. It's a single catheter that goes through the nose and into the esophagus. We have an esophageal balloon here and a gastric balloon in here. I'm not going to focus on those today, but in between those 2 balloons, we have several pairs of EMG electrodes. And that's right where this dome-shaped muscle is. There's your diaphragm in gray. So if we were to zoom in on this catheter, you can see, let's see if this, okay, there we are. So this is what the catheter looks like, and you can see the various pairs of electrodes. So here's pair 1, 2, 3, 4, and 5. All of these little vertical blips that you're seeing in regular intervals, that's all cardiac artifact that we have to deal with later in our analysis. The 3 big bursts that you're seeing on each of these channels, that's representing a contraction of the diaphragm. So they're taking a breath in. And the older generation catheters were problematic during exercise because they only had 1 or 2 pairs of electrodes. And so when we breathe, we can breathe at a high lung volume in and out, or we can breathe at a low lung volume in and out. And if you don't have enough electrode pairs, you're not going to capture that activity when their operating lung volumes change. So this catheter allows us to capture the diaphragm activity regardless of where they're breathing in terms of their operating lung volumes. And so when we're doing our analysis, we simply take the channel that has the highest amplitude signal for a given breath. And we use this measurement as an index or a surrogate measure of respiratory neural drive. And I'm going to show that here schematically with this brain. And so what we do is we can look at the ratio between diaphragm EMG, our so-called neural drive to breathe, on the numerator, and then on the denominator we have the tidal volume or the mechanical output of the respiratory system, which I'm showing here in the picture of the lungs. I'm going to show you what this ratio does during an exercise test that progressively gets more difficult. So normally in a healthy individual, there's this very harmonious relationship between the drive to breathe coming down and the corresponding mechanical output or the tidal volume response of the respiratory system, which is why I've made those arrows the same size. So the brain says you need to breathe more, and then the respiratory system rewards us with the appropriate increase in tidal volume, such that this ratio remains relatively constant throughout exercise. It does increase as exercise continues because even in health, our tidal volumes do eventually plateau. But in interstitial lung disease, for a variety of reasons, they have extremely high levels of respiratory neural drive. But because of their fibrosis, their lungs are very stiff, they can't expand their tidal volume. So in this scenario, the patient with ILD, the brain is telling them, you need to breathe a lot more for this given exercise intensity, but they simply can't. And so you get this uncoupling or this dissociation between the drive to breathe and the mechanical output of the respiratory system, which is why this ratio is so elevated at rest and why it continues to increase quite dramatically throughout exercise compared to the healthy individual. We think this is a very key component to understanding dyspnea. So my very first PhD student, Michelle Schaefer, she wanted to look at some of these parameters in interstitial lung disease. And what she did is she looked at dyspnea, which is on the y-axis, measured using the 0 to 10 Borg scale, and she plotted the dyspnea ratings against diaphragm EMG, our surrogate measure of respiratory neural drive. And then she also plotted it against tidal volume, this time representing the mechanical output of the respiratory system. And then finally, she plotted it against the ratio between diaphragm EMG and the tidal volume. And what she found, in all cases, there were strong and statistically significant correlations between dyspnea and these various parameters. But it was diaphragm EMG on the left that had the strongest correlation. And so this has now been replicated in COPD, in cystic fibrosis, and in healthy populations. So it seems that of all the physiological measures we make during a cardiopulmonary exercise test, diaphragm EMG seems to be one of the strongest correlates with dyspnea. Now, briefly, gas exchange is also impaired in interstitial lung disease. You can see here in the healthy lung, you've got all these densely packed alveoli, the pulmonary capillaries surround that, and you have this very thin blood gas barrier. It needs to be thin so oxygen can diffuse from the alveoli into the blood, and so that CO2 can go from the blood into the alveoli and it can be removed through exhalation. When you have all the scar tissue formation in people that have pulmonary fibrosis, you basically increase that distance for diffusion. So it becomes much more difficult for oxygen to get across that blood gas barrier, which is why they become very hypoxemic, especially when stressed with exercise. And this is a paper that we published a few years ago, just looking at oxygen saturation measured with pulse oximetry during a 6-minute walk test. Normally in a healthy person, our oxygen saturations would stay around 98 the entire time. It shouldn't really drop very much at all. In COPD, you do see they start at a lower saturation and they get down to around 92%. And a large sample size here, 274 patients. And in our ILD patients, we see greater degrees of hypoxemia. So they drop down to the high 80s in this study. And when we're doing exercise testing in the lab on a bike and doing more stressful exercise testing, we often see saturations getting into the low 80s and certainly in the 70s as well in some patients. I know this is a very busy slide. I'm not actually going to go through pretty much anything. I just want to give you an appreciation for how complex the pathophysiology of ILD. You have all these key characteristics like fibrosis, alveolar capillary membrane thickening, all of these things ultimately cause a very complex series of events that impact everything from breathing mechanics to cardiovascular function, to metabolic responses, to gas exchange problems. And all of these things ultimately in a highly interconnected way contribute to symptoms such as dyspnea, fatigue, and ultimately exercise intolerance. So when we look at this, we want to think, well, what intervention can we use that will address some of these things, and ideally multiple things? And so the one we thought of was, well, supplemental oxygen. Supplemental oxygen should address many of these limitations experienced by people with interstitial lung disease. So the next step is, well, let's go through the literature and see what's been done. So this was one study in 7 subjects with ILD. They did 2 incremental cycling tests, breathing either room air or 60% oxygen. And room air is typically around 21%. So they ended up doing these exercise tests and they found significant improvements in both exercise duration and peak work rate. However, they show no difference in dyspnea, but they only measured dyspnea at peak exercise. And I'm going to revisit this a little later and explain why it's very limiting to focus at peak exercise. Instead, we should be focusing on submaximal exercise. A more recent, pretty well-controlled randomized control trial did a study in 20 patients with idiopathic pulmonary fibrosis. Again, this is the most common interstitial lung disease. And they looked at ambulatory oxygen versus room air during a 6-minute walk test. And they delivered the oxygen through these nasal prongs at 4 liters per minute. And they measured dyspnea at the end of a 6-minute walk test. And in this study, there was no significant improvement in either dyspnea or 6-minute walk distance. However, when you interrogate the data, you'll see that the level of saturation didn't improve that dramatically with this type of oxygen. And this is not surprising with nasal prongs. You get dilution with the ambient air. You can only use such a high flow rate before it becomes very uncomfortable for the patient. Whereas when you use something like 60% oxygen, you have a lot more control. Okay, so this was a systematic review published 3 years ago on the effects of oxygen therapy in ILD. And basically they showed some beneficial effects for exercise performance, but no effect of oxygen therapy on dyspnea. And we had a really hard time believing this. Based on what we know about the physiology, oxygen should be reducing dyspnea. And so the question is, does hyperoxia or supplemental oxygen actually work in these patients? And from our perspective, we felt that the exercise protocols that have been used in the past, the way oxygen has been delivered, and the way dyspnea has been assessed by focusing only on what happens at peak, we think these factors likely contributed to an underestimation of the true beneficial effects of this intervention. And so that led to my first PhD student's project, Michelle, and the purpose of her study was to look at the effects of hyperoxia on dyspnea, endurance time, and physiology in 20 patients with fibrotic ILD. Many of you that are not in the physiology field may think this is a very small sample size, but it took us over 2 years to recruit these 20 patients. These are very challenging studies, and it's a challenging population to recruit. So each participant went through 4 visits. Visit 1 was a screening and familiarization visit. Visit 2, they did an incremental cardiopulmonary exercise test, and we did this to determine their peak work rate, which was then used to set the intensity for their constant mode exercise tests for visits 3 and 4. So on one of these tests, they breathed room air, and on the other test, they breathed 60% oxygen. It was randomized, counterbalanced. And here's what the setup looked like. So what you have here is our patient on the bicycle. She's breathing in through this tube, which is connected to this reservoir bag on the left. And that bag is being filled constantly during the test with either room air or 60% oxygen. And she's, of course, blinded to the condition. And so our participants did 75% of their previously determined peak incremental work rate, and they just exercised for as long as possible. We assessed dyspnea using the 0 to 10 category ratio Borg scale. And unique to the study is that we wanted to also look at the qualitative descriptors of breathlessness during the actual exercise bout. So we gave them 4 options that they could select. My breathing requires more work and effort. I cannot get enough air in, I cannot get enough air out, or none apply. And we asked them to anchor these to their resting state. And most of us would almost always select phrase number 1 throughout the entire test, even at maximum exercise. All right, going straight into the results. Here we have endurance time on the y-axis on the left, and this is the group mean data. So our participants lasted on average about 10 minutes. And then with the hyperoxia, they lasted almost double. They increased by 89%. So that was highly significant. When you look at the individual responses, you can see the vast majority of people had a positive bar, which indicates an improvement. And the minimal clinically important difference, we don't have this data in ILD. We're basing this on the literature in COPD. It's about 1.5 minutes. And you can see the majority of our patients exceeded the MCID, and some of them exceeded it by a dramatic margin. All right, this is the one that I really want to focus on because no study up to this point showed a beneficial effect of hyperoxia on dyspnea. And we measure dyspnea at ISO time. ISO time is the highest submaximal measurement time that was achieved on both the room air and hyperoxic trials. And we see the dyspnea response in the normoxia or the room air, and then the hyperoxia or the supplemental oxygen. We saw a reduction about 43% or a 1.9, almost a 2-unit difference on the 0 to 10 Borg scale. And to put that into context, the minimal clinically important difference for the Borg scale is 1 unit on the 0 to 10 scale. And so here are the individual responses. Negative bars this time indicate an improvement or a reduction in dyspnea. And you can see the majority of individuals had an improvement in their dyspnea, and many of them exceeded that minimal clinically important difference of 1 unit. Now, we were really excited about this data because no one has actually used this approach during an intervention. And so what we found was that this second phrase, I cannot get enough air in, this is the one we were really interested in. I'm just going to call it unsatisfied inspiration for our purposes. So unsatisfied inspiration occurred in 15 out of the 20 subjects in room air at some point during exercise. However, the onset of this unpleasant dyspnea descriptor was eliminated altogether in 4 people, and it was delayed. The onset of that phrase, selecting that phrase, was delayed by 8.2 minutes in the remaining 11 subjects. So not only is hyperoxia reducing the intensity of dyspnea, but it's also changing the qualitative descriptors of this symptom. Okay, for some of the physiologists, you'll like to know what happened to saturation. Well, the beauty of giving them a high FiO2 of 60% and not doing it through nasal prongs and having dilution through the ambient air is they're getting 60%. And that's why their saturations were essentially normalized. We brought them right up to about 98%. As expected with hyperoxia, your drive to breathe comes down, so ventilation decreases. And that was mediated in part by a modest reduction in tidal volume on the bottom left, but also the breathing frequency. So they were adopting a less rapid and shallow breathing pattern with hyperoxia, which is also beneficial. We wanted to look at some of the correlates with the improvement in exercise endurance time. And some of the things that came out included oxygen saturation, ventilation, and inspiratory lung volume. But the one that was most strongly correlated was the improvement in dyspnea. So those that had the greatest reduction in dyspnea had the greatest improvement in endurance time. Unfortunately, we didn't see any physiological measures significantly correlate with the improvement in dyspnea. It was just that endurance time and dyspnea relationship. So we wanted to interrogate this further using our Diaphragm EMG catheter. And so just to refresh your memory, this is a catheter here. A diaphragm EMG is our surrogate measure for respiratory neural drive. And we found that at ISO time, there was a 27% decrease in diaphragm EMG. If you recall, when I talked before about neuromechanical uncoupling, I said in health, there's this very nice matching between the drive to breathe coming down and the mechanical output of the respiratory system. That's in health. And then I said in disease, you have this disproportionate increase in the drive to breathe relative to what the respiratory system can perform in terms of expanding tidal volume. So we looked at this and we've also found a significant improvement in this ratio, a 15% improvement. And sure enough, the only thing that correlated with the improvement in dyspnea, other than, of course, endurance time, was that measure of neuromechanical uncoupling. So hyperoxia is doing something to optimize that relationship between the drive to breathe and the mechanical output of the respiratory system. Okay, I want to go through an individual example to revisit this idea of why studying peak dyspnea responses can be very problematic. So here's one of our patients. We have dyspnea on the y-axis on the 0 to 10 Borg scale. On the x-axis, we have her exercise time. And this was what she did in room air. Very short exercise bout. She lasted 7 minutes. The dyspnea intensity ratings increased very abruptly to intolerable levels, and then she had to stop. And then on another visit, she did hyperoxia. And again, she doesn't know which gas she's getting. And this was her response. Obviously, an extreme case, she lasted well in excess of 40 minutes with hyperoxia. But most people in exercise physiology like to focus on just what's happening at peak exercise. And the problem when you do this when studying symptoms like dyspnea is it can be very misleading when there's an improvement in performance. So here, the conclusion is actually, if we just limited our evaluation to peak data, we would say that dyspnea got worse with hyperoxia. It went up by 1 unit. But the way you're supposed to study symptoms, whether it's pain or dyspnea, is you have to standardize the stimulus intensity. And so here, both tests are performing the exact same work, but you have to be measuring them at the same time. And so this is what we called ISO time. And you can see here a dramatically different story, a 5-unit reduction in dyspnea, which obviously is well in excess of the 1-unit minimal clinically important difference. And remarkably, she was able to stay at a Borg rating of 2 for like 15 minutes, and then it only gradually increased. So clearly you lose a lot of information when you isolate your analysis to peak. This woman emailed Michelle, my PhD student, and she said, I would like to try this being oxygen, in order to exercise more, which hopefully will make me feel stronger. I would love to go back to the gym. Due to my breathlessness, I really have stopped these activities over the last few years, as it has been too discouraging not being able to do what I once could. However, that 43-minute bike ride has definitely inspired me and made me realize that I am in better shape than I thought. This woman got an engineer to modify her bike, get an oxygen canister on it, and she went on a bike tour in Europe. She is a remarkable woman. You're going to see a clip of her in a video that I'm about to show. But this is really inspiring to see as a researcher, because this is exactly what we're trying to accomplish. We're trying to come up with therapeutic interventions that can unload the burden up here on their respiratory system so that they can push their locomotor muscles more and get all of those benefits that you and I get from exercise training. Another one of our participants said, this was the first time I can remember my legs feeling tired from exercise. So again, we unloaded that burden on his respiratory system and allowed him to push his legs to a greater degree during the cycling. Now, the final step is, so I showed now, first there was a clinical problem, which was dyspnea. We identified mechanisms of dyspnea. We came up with an intervention that improved dyspnea during an acute bout of exercise. Now what happens when you give people oxygen during exercise training for several weeks? And this is known as the HOPE-IPF trial. This is a large, multi-center clinical trial that we're running. It's an 8-week exercise training study. We have 88 patients with idiopathic pulmonary fibrosis that are going to be enrolled, and all of them are being treated with the same background antifibrotic therapy, nintedanib. And this is a drug made by Boehringer Ingelheim. So they're sponsoring this study, but I just want to make it very clear that we are only looking at the effects of hyperoxia, as all participants are getting the same background pharmacotherapy. So one group, 44 patients, will exercise train 3 times a week for 8 weeks, and they'll be getting 60% oxygen. The other group will get what we're calling standard of care, basically room air exercise, and they'll get just the smallest amount of supplemental oxygen needed to keep their saturations at around 88 to 90% if they desaturate more than that. So the goal is, with pulmonary rehabilitation, the challenge we face is that many of our patients, they don't derive physiological benefits because they're just too weak. They cannot push their locomotor muscles hard enough to get all of those key adaptations that you and I would get from training to our locomotor muscles, metabolic adaptations, cardiovascular adaptations. So the hypothesis here is, if we can give them this extra oxygen, maybe they can train at higher intensities and for longer durations compared to standard of care, and that should in theory translate into improved outcomes. This is a very large trial. We have 8 sites in Canada. We have our site, of course, is the primary site, but we also have sites in Kelowna and throughout Canada. It requires a very large collaborative team. This is my first major RCT that I'm running. I'm leading this with my colleague, Chris Ryerson. And each site has an exercise physiologist like myself, paired with 1 or 2 respirologists that specialize in interstitial lung disease. It's a really unique partnership. We're about 60%, 70% through data collection, but unfortunately the study is now on hold because of COVID. We technically can collect data, but this is a very high risk population, so we're going to wait until there's a vaccine before we continue. So with that, I just want to end with a video. And again, I apologize to the people that were at my CSEP presentation. I'm showing this video again. I just think it's really inspiring. The real video is much longer. It's about 10 or 12 minutes. This is a 4 or 5 minute edited version just for the purposes of this presentation. So I hope you can see it and hear it.
I've been competing in endurance sports for over 15 years now, and most recently I've been competing in mountain running. I study exercise because I believe so strongly in the value of exercise, and you should study what you care about. I'm a clinical exercise physiologist, and my research program studies breathlessness and exercise intolerance in patients with chronic lung conditions.
I knew I had lung problems for quite a while. I was misdiagnosed many times.
I developed a cough with a cold, and the cough just never went away.
You start having problems with hills, you start having problems with steps, problems with really any type of exertion.
Nancy thought I looked really bad and said we should go into hospital and get a chest x-ray.
He called up the image on our computer screen at home, and we both looked at it. We were totally shocked and totally devastated.
It looked like a terminal lung condition. And ultimately, I would need a lung transplant.
Interstitial lung disease is really an umbrella term that encompasses well over 150 different diseases characterized by scarring of the lungs and inflammation. The most common interstitial lung disease is idiopathic pulmonary fibrosis, and the average survival is around 2 to 3 years from the time of diagnosis.
From the day of his diagnosis, I said, Don, your lung condition is going to continue to get worse and worse, and we have to make you more and more fit. And that was the first day of our walking together.
I wasn't exercising because as soon as I tried to, I remember trying to run one time and I took about 10 steps and started coughing.
One of the biggest challenges individuals with interstitial lung disease face is this very distressing symptom of breathlessness.
You can't get a big breath. It feels like you've got something wrapped around you.
You become able to do less and less.
You know, you just have to hold yourself because it feels like you're going to break your ribs. You're trying to get your breath and you're coughing so hard. It's very scary.
To me, it seemed logical that breathing high levels of oxygen should reduce symptoms of breathlessness, but when I looked through the scientific literature, I couldn't really find any evidence to support that. And so we wanted to carry out a study to look at the role of high levels of oxygen to reduce breathing discomfort during exercise. Funding from the BC Lung Association helped support equipment for my lab and also the salary support for a promising PhD student to carry out this study as part of her doctoral thesis.
When I first started this research, I found the prognosis to be really striking. You have these symptoms and there's not much they can do to bring them down. So from the research perspective, I found that there was a really great need.
I was deteriorating physically because I wasn't able to do things.
One of my first patients that came into the lab was Barbara, and I was pretty green in research, and this was a big deal for me. It was my first clinical exercise study.
I had wires everywhere. I had headgear on. They were measuring my breath.
We put her through a full battery of breathing tests. We got her on the bike and made her exercise for as long and as hard as she could.
The speed they asked of me was pretty fast, and after 7 minutes, I couldn't do it. I had to stop.
When she came in again and we gave her this supplemental oxygen, she actually lasted for 43 minutes. All of us were pretty shocked by this. We were looking around at each other. We had to draw more lines into our data collection forms. I was checking the bike to see if the resistance somehow let up because it was such a profound improvement.
With the help of oxygen, I was able to do so much more.
We tested 20 patients with interstitial lung disease for this study, and the magnitude of improvement we saw was unlike anything we've seen in the literature. We were able to publish the results of this study in one of the top-ranked respiratory journals in the world, and then we were able to take those results and secure over $2.1 million to take this intervention across the country.
We recently launched a multi-center national clinical trial at 8 different sites across Canada, and the premise of that clinical trial was the preliminary results of my doctoral research. Oftentimes you hear of these exciting things going on in the lab, and then those exciting ideas never leave the lab. And something unique about the studies that we're doing, I see them already translating outside of the lab. So we're affecting the lives of these patients, and they're carrying it with them. The fact that I'm able to actually impact the life of another individual, I think, is huge.
All right, I hope that worked for some of you. Just to summarize the presentation today, revisiting that sort of framework of doing rehab research, we identified the clinical problem of dyspnea. We were able to characterize some of the mechanisms of dyspnea. We identified that diaphragm EMG is a key contributor, and we knew that hyperoxia could reduce diaphragm EMG. And we identified the therapeutic target of oxygen. We conducted an RCT, so we looked at the acute physiological effects of oxygen, and we showed improvements in dyspnea and exercise performance. That was Michelle's doctoral thesis. And now we are looking at what happens chronically if we use oxygen during several weeks of exercise training. And we've got a similar thing going on right now for skeletal muscle dysfunction. I don't have time to talk about that today, but that's our next step in our ILD research. So with that, I'd like to thank everyone for being here today. I want to thank my lab and funding. I especially want to thank Michelle for all of her work, and my collaborator, Chris Ryerson. He's co-PI on all of these projects. He's just one of the leading ILD respirologists in the world, and none of this work can happen without his support. He's instrumental in recruiting participants. He comes to the lab despite being incredibly busy to help supervise our exercise tests. So we're all indebted to him. So thank you very much. And I guess we have some time for questions. I'll be happy to answer any questions you have.
Okay, well, thank you very much, Jordan, for the great talk. So yes, we have time for questions. Yeah, please send them to me in the chat if you want to talk, or if you want to take the mic right now, that's also fine. If there's no question, I'll take my my position right now to maybe ask a question, Jordan, to you, like a simple question about EMG and if I understood the axes correctly, like you seem to be normalizing the diaphragm EMG to a maximum contraction.
Yeah.
And I'm just wondering what that represents, a maximum contraction of the diaphragm, if like how that's done.
So the way we do it in the lab is there's a number of ways you can get maximum contraction. You can do a maximal inspiratory capacity maneuver during exercise. So there's breathing along and then huge breath in, and then we can get it there. We can get it from a sniff maneuver where they sniff as hard as they can through their nose, or you can do it by sucking in through a semi-occluded mouthpiece, which is how you would normally get maximal respiratory pressures. We've done all of these, and we consistently see that the maneuver that gives us the most activity is the inspiratory capacity maneuver during exercise. So we normalize it to that. But other studies, they don't normalize their data in all circumstances. Sometimes they just report it in absolute units, especially if they're doing a within the subject comparison.
Yep. Makes sense. Thanks.
No problem.
Yep. Other questions for Jordan?
Hi, Jordan. It's Steve right here. Thanks for a really nice presentation. Great to see how you brought that from the initial physiologic mechanisms right to an RCT. It's great.
Thank you.
I'm always interested in the time aspect of stuff like this during submaximal exercise, and I apologize if I missed it. But I'm curious with the effect of oxygen. You're interested in the delayed time to the sensation of unsatisfactory inspiration. Is that correct?
Yeah.
What do you think is the mechanism that's pushing that back in time? I don't know enough about the diaphragm fatigue literature to understand that part of it.
So I think these more unpleasant qualitative descriptors of dyspnea, like unsatisfied inspiration, I think they're largely driven by that neuromechanical uncoupling concept. And so given that we were able to reduce that throughout exercise, I think that's probably the driving factor in terms of delaying the onset of some of those descriptors, because as they progress through the test, you know, it's not going to be perfect. There will be some uncoupling occurring, but I think that's what it is. But it's a very hard thing to experimentally determine, unfortunately.
Yeah, absolutely. Thanks. That's interesting.
Okay, thank you. Do we have other questions from the audience?
I have a question. Jordan, in one of your first data slides, you had sort of 3 panels with all the sort of correlations in that. And in each of the figures, there was sort of like one line that was going down rather than up. Is that, I'm guessing that was the same person in each of the three panels. So. And was there anything unique about their medical history or training history that led you to believe
there's nothing that really stood out. The challenge for some people is they have a hard time understanding the dyspnea scale. So in that scenario, I think what would have happened is they just selected the same dyspnea rating throughout all exercise intensities. And it could be totally real. It could be a lack of understanding. We do everything that we can to familiarize everyone with the Borg scale. So we say, okay, 0 means no breathing discomfort at all. 10 is the most severe breathing discomfort you've ever experienced or could ever imagine experiencing. So we anchor both ends of the scale, which is why we don't see people getting 10s very often when we're testing patients. So it's hard to say. There's nothing specific about that, but it could be related to her understanding of the scale.
Cool. Thanks.
No problem.
Okay, thanks, Chris. Other questions? I'll give you a few more seconds to think if you might have something for Jordan while we have him here.
Hi, Jordan. It's Mick from Dr. Shields' lab.
Hey, Mick, how are you?
I would like to ask you about potentially the placebo effect associated with dyspnea and, you know, taking supplemental oxygen during exercise. Sure. Or, you know, the actual mechanism of measuring exercise metabolics and then associated dyspnea and placebo effect.
Are you asking if there could have been a placebo effect in this study?
Yeah, I guess so. And I guess what do you think is there a possibility to have a placebo effect associated with dyspnea?
I think it's possible. I think in this experimental design, we tried to control for that by having the participants blinded to the conditions. So they didn't know if they were getting a hyperoxia or room air during their constant load test. So we tried to address it that way. But I suppose, yeah, I think it's entirely possible that if you tell someone, hey, I'm going to give you this inhaled medication that's going to open up your airways, that there could be a placebo effect there. I can't rule that out for sure.
Oh, thank you.
No problem. I'm not sure if that's what you were looking for, but I think like anything subjective, whether it's perception of pain or dyspnea, I think there can always be a placebo effect. But we try to address that in the way we design our experiments.
Okay, well, thank you. Maybe we have time for a last one if someone has a last question. Okay, well, then I'll take this opportunity to thank you, Jordan, again, for a great talk. Thanks for accepting the invitation. That was great.
Thanks very much for having me, everyone. It's great to kind of be back with the kinesiology crowd. It's great to see all of you.
Thanks. And then for the grad students, you can stay if you want to have a little social afterwards. Okay, well, thank you, everyone, for attending today. And we see you at the next seminar.